طبعا diabetic kidney disease updates. طبعا احنا هنتكلم عن مجموعه items: introduction, epidemiology, pathology, and biomarkers, management, and closing at the end. طبعا دلوقتي لما عايزين نعرف طبعا حجم المشكله، احنا زي ما احنا عارفين ان الكوزز اوف ديث in 2016 كان الدايابيتس في المركز ال 15 والكرونيك كيدني ديزيز في المركز ال 16. الاكسبكتيشن من 40 او ان هيبقى الكرونيك كيدني ديزيز في المركز الخامس والدايابيتس في المركز السابع. So that we are speaking about a very critical issue really. طبعا as we can see for our problem طبعا here in diabetes in diabetic kidney disease, as we can see, represents the leading cause of chronic kidney disease and end-stage kidney disease, and it is responsible for about 27% of the cases, followed by hypertension. And in this study, which is China Kidney Disease Network, which is a very important study, when they have seen the risk of cardiovascular diseases in coronary heart diseases, stroke, heart failure, and AF, they have found always that the leader is diabetes mellitus, followed by chronic kidney disease. And in heart failure, chronic kidney disease is the leader cause for the mortality, followed by diabetes mellitus. What about epidemiology, presentation, and trends? As we know that we have variations of risk of end-stage kidney disease in type 1 diabetes mellitus. As we can see in these studies, in this situation, as we can see, according to different studies, the risk may be ranging from 15% up to 35% in different studies. While when we are speaking about the risk of end-stage renal disease among patients with type 2 diabetes mellitus, as we can see here, all over the whole history, usually the number of deaths are usually resembles a very high ratio among diabetic patients due to end-stage kidney disease situations. And when we are here, according to the USRDS 2019 annual report, how disease can present in diabetic patients, usually there is reduction of the GFR below 60 in 10% of the situation. There is reduction of albumin-creatinine ratio in about 20% of the patients. And we have also combined both of them, both the presence of reduction in estimated GFR and the increased albumin-creatinine ratio in about 10%. And the whole process in this situation, we are approaching 40% according to abnormalities which may occur in diabetic patients. Very important issue to know that we have an entity of non-albuminuric diabetic kidney disease, the risk of progression to end-stage kidney disease. As we know that previously, the classification of micro and macroalbuminuria is not present nowadays. We have normal albuminuria below 30, from 30 to 300 we have mild proteinuria or albuminuria, I'm sorry. From 300 to 1000 we have moderate albuminuria, and more than 1000 we have severe albuminuria. As we can see, the presence of albuminuria itself is a risk factor towards end-stage kidney disease, with of course the highest incidence of end-stage kidney disease when the proteinuria exceeds 1000 milligram per deciliter. As we can see, all over the history, with increasing the number of years from the baseline of discovery of diabetes mellitus, usually we have a higher ratio of progression towards albuminuria and sustained albuminuria. What about other risk factors? These articles show that systolic blood pressure is a very important issue in the occurrence of diabetic kidney disease, with the best blood pressure between 120 and 130, but higher systolic blood pressure will produce, of course, in this situation, declining of the estimated GFR below 60 milliliter per minute. In diabetic kidney disease, as we can see, the non-albuminuric parts usually have a lower risk factor of progression towards end-stage kidney disease, but with increase of albuminuria, we have a higher risk towards progression of the kidney disease to the stages, advanced stages, stage 4, and 5 with progression towards end-stage kidney disease. In cases of non-proteinuric, what are suggestive theories? If we have chronic hyperglycemia, if we have high systolic blood pressure, overweight and obesity, here we have hyperfiltration. The hyperfiltration will produce tubular hypertrophy, tubular tissue damage with glomerulosclerosis. While in cases with repeated minor episodes of AKI in patients with stable or slowly declining GFR, it's also producing glomerulosclerosis. And in female, of course, gender, estrogen increases the incidence of focal and segmental glomerulosclerosis and mesangial matrix expansion with progression towards glomerulosclerosis. So that it is not the whole process proteinuria, but we have other players rather than proteinuria. We have a new entity which is fast renal decline, which have changed our concept about diabetic patients and diabetic nephropathy. All of us know as that diabetic nephropathy is a chronic, slowly progressive disease over years, up to in 15 to 25 years. But here they have defined that we have a very new entities, the very fast, which means that the patient can end towards end-stage kidney disease within 2 to 6 years from the onset of diabetes mellitus. And here, the reduction of the GFR will be about more than 15 milliliter per minute per year. In the fast form, we have reaching end-stage kidney disease within 6 to 10 years, with the decline of the GFR about 10 milliliter per minute. Moderate forms, reduction per year will be 5 milliliter per minute, and it will occurs over 10 to 20 years. And the slow forms, which is the classic form, when we have a decline in the GFR per year less than 5 milliliter mercury, 5 milliliter per minute. And here the progression may be from 20 to 45 years. So that this is the new concept, that we have a new terminology, which is diabetic nephropathy with very fast progression of the kidney disease. How it can differ? What is the problem? The problem is that we have a 4 estimated GFR patterns, and this have led to the progression of diabetic kidney disease and trajectory of kidney function decline in Chinese patients. It may be very slowly progressive over the years. It may decline and it became stable for years and then declines again. It may take a slow progressive form declining, and it may have a fast progressive disease with very rapid decline and then plateau. So that it's very important issue to know that we have a different types of situations in cases of diabetic nephropathy. It is not all one issue. Understanding hemodynamics is very important, because that in several types of diabetes mellitus, with advanced diabetes mellitus, we have differences between the renal arterial pressure, the renal afferent arterial pressure, and renal efferent arterial pressure. With increase, of course, of glomerulosclerosis, this will lead to more progressive towards end-stage disease, and this is the play of the RAS system in this situation. Also, molecular pathology, it is not only one pathology. Hyperglycemia may produce genetic modification, may produce epigenetic regulation, may suppress podocyte autophagy and mitochondrial dysfunction. All of this will produce a lot of, as we can see, molecular pathophysiological pathways ending in mesangial cell expansion, and in our situation, glomerular dysfunction with proteinuria and inflammatory state, vascular dysfunction, and tubular interstitial disease. As we can know, trajectories in fast decliners, the effect of their modification. When we have onset of diabetes mellitus, sometimes if you have intervened early, you may delay the progression of end-stage kidney disease. Others, the early intervention may lead to a slower rate of progression towards end-stage kidney disease. While the late intervention, whatever that you are fast decliner or not fast decliner, you are losing your chance towards retarding the progression of the chronic kidney disease, and you reach towards end-stage kidney disease very rapidly. What about the pathology? As we can see, in diabetic kidney disease, we have two major predictors in the pathology: the segmental sclerosis and the extracapillary hypercellularity. When these two issues are present, these are predictors towards end-stage diabetic kidney disease. As we can see here, we have in this situation, we have, as we can see, FSGS, while in this we have mesangial expansion. And they have found that the more that you have segmental sclerosis, and this situation, the more you will reach towards end-stage kidney disease, and the more that you have mesangial expansion, you have a higher chance to reach end-stage kidney disease. Recently, there are predictors of non-diabetic kidney disease. So that if you have found these predictors, you should think that the issue is not diabetic kidney disease or diabetic nephropathy, it is something else, through measuring serum levels of immunoglobulin G and complement 3, which can differentiate non-diabetic renal disease from diabetic nephropathy. As you can see, the reduced immunoglobulin G, usually present in nephrotic syndrome, and the increased complement 3 levels denote that you have non-nephrotic, of course, syndrome, and both cases you have here no diabetic nephropathy, you have non-diabetic kidney disease. So these markers may help you to differentiate if you have diabetic nephropathy or other causes of diabetic kidney disease. And in biopsies, as we can see, we have the two issues. We have the non-proteinuric issue and proteinuria. Of course, the non-proteinuric are less, but we should state that when you have proteinuria, here the rate of decline according to the Fayette classification and Tervert classification towards end-stage kidney disease is higher. And these diagrams can show that the non-proteinuric patients have a better renal survival rate, have a lesser incidence to reach end-stage kidney disease. But if you have proteinuria, of course, your incidence towards end-stage kidney disease will be higher. So that diabetic kidney disease is not one entity. You may have diabetic nephropathy, you may have non-diabetic kidney disease, you may have hypertensive nephrosclerosis, recurrent urinary tract infection, of course, obstructive uropathy and neurogenic bladder, and type 4 RTA. And as you can see, now the trend is changing. A lot of cases, in cases of diabetic kidney disease, are not due to diabetic nephropathy, it is rather than due to other causes. And in this situation, sometimes you may have overlap, so that sometimes we are deceived. You may have diabetic nephropathy and the other cause of non-diabetic nephropathy, so that don't mean that. You should search for other causes rather than non-diabetic nephropathy for proper treatment and not to miss the case in your diagnosis. And if you have combined element, you should search for that so that you can control diabetes and you can treat the other cause of non-diabetes mellitus, so that now we have isolated non-diabetic renal disease, pure diabetic nephropathy, and combined, so that please don't miss the non-diabetic issue and the combined with diabetic nephropathy. Usually when you have diabetic nephropathy, you have albuminuria and you have progressive chronic kidney disease slowly over a longer time. And this is usually the natural history. In stage 1 and 2, which in the pre-stage, in this situation, you have hyperfiltration in this situation and just renal hypertrophy. When you have incipient diabetic nephropathy, which means in stage 3, you have microalbuminuria, hypertension with mesangial expansion and thickening of the arterioles. When you have over diabetic nephropathy, here we have over proteinuria, nephrotic syndrome with reduction of the GFR, and either the localized form, Kivlenstein-Welch lesions, or tubular interstitial fibrosis. And lastly, after a very long time, as we can see, it may exceed 25 years, you will reach end-stage kidney disease. So that other diseases may occur and may mislead you. You have here no diabetic nephropathy, but you have other disease such as membranous nephropathy, minimal change disease, FSGS, IgA nephropathy, thin-based membrane disease, proliferative GN, and other immunological diseases. And this study have shown us that non-diabetic renal disease may occur alone in 36% of situation, 1/3 of the cases, while when you have with diabetic nephropathy, you have 27% of your situation. This means that you have more than 60%, 2/3 of the cases, you have in pure diabetic nephropathy, you have other players, so please don't miss these players and try to treat them. Here, other pathological diagnosis rather than diabetic nephropathy, so please, you don't miss the presence of other pathological diagnosis for proper management in this situation. What are the keys? Short duration of diabetes mellitus, rapid decline GFR or progressive rise of the creatinine, rapid increase in protein excretion, and acute onset of nephrotic syndrome, active renal sediment, and signs or symptoms of other systemic disease such as lupus or vasculitis or others, absence of diabetic retinopathy, refractory hypertension, and significant reduction in GFR after ACE or ARBs application. So that in this situation, you should think about another disease and you should think about to take a renal biopsy. So that, as we have mentioned previously, you have certain criteria that favors you that you have diabetic nephropathy, such as persistent albuminuria, bland urine sediment, slow progression of disease, lower GFR, and others, while you have other players, as we have mentioned previously, that may divert you toward that you haven't here diabetic nephropathy, you have other diseases combined with diabetic nephropathy, or it is the only disease and you have no diabetic nephropathy, so that please don't miss that. And hence, a very important question, when to take a renal biopsy in these patients. As we can see, when you have diabetes and proteinuria, you have several possibilities. So you should exclude urinary tract infection. You should see urine sediments, red cells, and others. Of course, quantitation of proteinuria, renal ultrasound, serology for other diseases. In some situations, you have typical diabetic kidney disease, so you have no need for renal biopsy. If you have type 1 diabetes for more than 10 years, retinopathy, previous microalbuminuria, no macroscopic hematuria, no red cell casts, large kidneys on ultrasound, there is no need for renal biopsy. And the only indication, if you have atypical proteinuria with type 1 diabetes for less than 10 years, no retinopathy, nephrotic range of proteinuria without progression through microalbuminuria, which means that you have discovered the patient suddenly with nephrotic syndrome or rapid progression of proteinuria without passing through microalbuminuria, macroscopic hematuria, red cell casts, you should proceed for renal biopsy. But don't miss that in certain situations, you may have a typical situation, but there is no indication for renal biopsy. If you have azotemia with proteinuria less than 1 gram, papillary necrosis, hematuria and scarring, tuberous sclerosis, pyuria hematuria, renovascular disease, of course, if you have ischemic kidney disease, if you have hypertensive nephrosclerosis, if you have the use of non-steroidal anti-inflammatory drugs in some situations, in these situations, there is no indication for renal, of course, biopsy, because you have other obvious cause that can justify you not to take a renal biopsy and to treat your patients. What about biomarkers? You have a different biomarkers that may help you in cases of studying diabetic kidney disease and mechanism and source. In case of inflammation, you may find tumor necrosis factor and tumor necrosis factor receptors. And in case of fibrosis, you may find connective tissue growth factor and transforming growth factor beta. Angiogenesis, you may find vascular endothelial growth factor. In endothelial dysfunction, you may find the amino terminal pro-C-type natriuretic peptide, mineral metabolism, the FGF23, tubular injury, the NGAL or kidney injury molecule, or epidermal growth factors. What about other recent predictors for progression of kidney disease? The total bilirubin. The higher the total bilirubin, because it is filtered through the glomeruli and excreted through the tubules, in this situation, you may predict that your patient may have a more incidence towards end-stage kidney disease and survival. If you have found that your serum bilirubin more than 0.44 milligram per deciliters, in this situation, here your survival rate will be less and your incidence of end-stage kidney disease are lesser than lower serum bilirubin level. Don't miss that here the history of this is changing and your diagnostic procedures are changing and the whole process is changing. It is not just measuring blood glucose level, serum albumin, protein creatinine ratio in urine or albumin creatinine ratio in urine and so over. No, we have a lot of issues. We have genomics, epigenomics, transcriptomics, and proteomics and metabolomics. Genomics, to know the sequence of the gene, and this may help you in prediction of disease susceptibility and prediction of drug response and diagnosis. Epigenomics, to know the environmental factors that can change the disease, such as epigenetics, so that it may help in cases of prediction of disease onset and discovery of novel drug targets and modulation of lifestyle and others. Transcriptomics, the sequence of transcription of the messenger RNA, this may help you in identifying circulating biomarkers and discovery of novel drug targets and improvement of diagnostic accuracy. Proteomics, which means that the sequence of proteins that the fingerprint of each type of diabetic affection and diabetic nephropathy and other kidney diseases such as membranous and others, which may help you in diagnosis and management. Metabolomics, this means that to know that the metabolic pathways which are responsible for the pathogenesis of diabetic nephropathy, and this may help you in identification of the onset of the disease, its progression, and to identify the drug of choice in your management. What is meant by human exposome? This is a very important new issue to be considered, that you have a normal human, of course, gene. When it is exposed to certain environmental factors, it's known as exposome, so that you should know what are other modifiable environmental factors that may help you towards management in your situation. What about the factors that are known as CRES? These are kidney risk inflammatory signatures. From among 194 factors, they have found that 17 factors may have a significant process in inflammation in diabetic kidney disease and its development towards end-stage kidney disease. Most of these factors is related to tumor necrosis factor receptor soluble factors with several types: interleukin 15, interleukin 17, CD55, and the chemokines receptors and the chemokine ligands and others. And a lot of studies have been done in that to identify these 17 main players with the major impact for the tumor necrosis factor receptor soluble processes. And according to this, they have found that if you have used certain drug such as parasitinib, which is JAK1 and 2 inhibitors, this of course drug may help you in suppression of certain inflammatory cytokines, and it may retard the progression of diabetic kidney disease, so that it is very important for that. What about management? Always our dream is reversal of diabetic nephropathy. Is it true? Yes, is it true? After pancreatic transplantation, they have found that there is regression of your pathology inside the kidney. Up to it may have reached normal after 10 years of pancreatic transplantation. And so that this is maybe a hope that it is not a progressive one-way disease. This disease may be reversible. So that in this situation, you should put all your target how to treat diabetic kidney disease properly through the new oral therapies, which proven benefits beyond glycemic control. And I think my dear colleague, Dr. Yasser, have a lecture that he will speak about these drugs. Weight loss is very important, blood pressure reduction, cardiovascular protection, because this is the major, of course, cause of mortality, and to delay and to retard the progression of chronic kidney disease. Usually when you have risk factors, you have non-modifiable risk factors such as gender, age, presence of diabetic retinopathy, neuropathy, and of course, ethnicity, genetic disability, and these are non-modifiable, but you are always playing upon the modifiable factors such as hypertension control, body mass index reduction, and poor diabetes control to be well controlled. So that prevention of diabetic kidney disease, the role of glycemic control, so that intensive control of blood glucose level is very important. And the guidelines have mentioned that your target hemoglobin A1C may be around 7, and in younger population with no other risk factors, not fragile population, you can reach up to 6.5%. But don't miss that these patients has higher incidence of hypoglycemia, so that the patient with risk of hypoglycemia, don't try to make your blood glucose level, hemoglobin A1C, I'm sorry, below 7%. And if you have other comorbidities, older population, liver cirrhotic patients, chronic liver disease, chronic airway disease, and chronic cardiac diseases, you should, of course, you may raise your target above 7 up to 8 and higher levels. So that in your management, individualization is very, very important according to the age of your patient, the situation of the patient, the fragility of your patient, and other comorbid conditions. What about smoking in this situation? They have found that diabetic patients, when they are smoking, there is increased incidence of chronic diabetic kidney disease. There is increased incidence of cardiovascular mortality, and there is increased incidence, of course, of overall mortality. So that cessation of smoking have found that you can retard the progression of chronic kidney disease and other cardiovascular diseases. What about sleep disorders? It is very, very important to ensure that your patients may have a very good sleeping pattern, because they have found that the presence of sleep disorders breathing, because of the hypoxia, of course, in the kidney, hypoxic nephropathy, will increase albuminuria, which may, of course, lead to more progression of the diabetic kidney disease. And so that please ensure that the patient have a good sleep quality without sleeping disorders in breathing. And what about the risk of sustained obesity? Acceleration of body mass index in early childhood and risk of sustained obesity. This is very important. There is something known as adiporenal axis. As we know that the healthy adipocytes will produce certain substances that may help to preserve the kidney functions. But if you have adipocyte hypertrophy in this situation, there is a lot of derangement, okay? Increased several markers such as increased leptin, decreased adiponectin, increased angiotensin 2, increased human necrosis factor, and others. This will help the occurrence of albuminuria and fibrosis, inflammation inside the kidney, with progression towards chronic kidney disease and end-stage kidney disease. When the kidney deteriorate, it will increase urea and other uremic toxins. They are approaching above now 592 toxins, homocysteine toxin, that it will increase inflammation, insulin resistance, and of course will lead to loss of energy and what is known as malnutrition, cachexia, uremic syndrome. So that in this situation, don't miss that several barriers such as leptin, transforming growth factor, when they are increasing, they will of course stimulate the adipocyte for increasing other fibrotic agents that will produce more inflammation and fibrosis in the kidney, which will have a deleterious effects, of course, in cases of diabetes mellitus. What about metabolic syndrome and chronic kidney disease? As we can see here, usually metabolic syndrome is associated with increased chronic kidney disease. This is a meta-analysis that have shown us that if you have more metabolic kidney disease, you have a higher risk of chronic kidney disease. Metabolic syndrome, you have higher risk of chronic kidney disease, increased fasting glucose, increased blood pressure, increased lipids, obesity. All these are factors that will help in deterioration of and occurrence of chronic kidney disease. But if you have controlled these factors, you may help in retarding progression of chronic kidney disease. Don't miss that it is not only diabetes. If you have impaired glucose tolerance or impaired fasting glucose, here you have a hemodynamic change inside the glomeruli, and it will increase, of course, resistance in the arteriole and increase in the intracranial pressure, and it may, even without the presence of frank diabetes mellitus, you may lead these patients towards deterioration of your kidney functions. So that if you want a remission in diabetic patients, so weight management is very important. This study have shown that weight reduction will help up to 46% of people who have reduced 15 kilograms over 1 year. This will help in remission of diabetes mellitus and retardation of progression of chronic kidney disease. Here we have in this study the Camellia TIMI61 study, which they have used lorcaserin, which is a selective serotonin 2C receptor agonist. In this situation, progressive reduction of your body weight have helped, of course, in reduction of the incidence of diabetes mellitus and more control of diabetes mellitus and the prevention of new onset diabetes mellitus with preservation of the kidney functions. So that you have also, while you are treating chronic kidney disease, you should make primary prevention for cardiovascular disease. This must be, of course, based on proper nutrition plan, proper control of hyperglycemia. These patients, they are advised to do 150 minutes per week of moderate intensity physical activity or 75 minutes of vigorous intensity, which means 20-25 minutes per day. And for type 2 diabetes mellitus, usually metformin is a first line of therapy, and it may help in this situation. And for type 2 diabetes mellitus, you can reduce cardiovascular risks through the sodium glucose transporter SGLT2 inhibitors and glucagon-like receptor 1 receptor peptide. And this, of course, I will not discuss these issues because my dear Professor Dr. Yasser in later lecture will discuss that in therapy. Carbohydrate quality and human health is very important to increase carbohydrates with total fiber content, so that nutritional therapy and lifestyle modification are very, very important for proper control of diabetes mellitus and retardation of chronic kidney disease. They have found that vegetarian diets and chronic kidney disease. What's occur? If you have vegetarian diet, as we can see, you will help in preservation of the glomerular filtration rate, and you'll decrease cardiovascular complications through multiple, of course, pathogenetic mechanisms. What about tannins and diabetic kidney disease? They have found that tannins sometimes from different, of course, type of food, as we can see, they may act as antioxidants and antifibrotic agents, and they may preserve the kidney function, the GFR. And here, the Predian trial have shown that another, of course, benefit for pentoxifellin, which have retarded the progression of diabetic nephropathy, as you can see in this trial. What about hypertension? Hypertension here, proper control of blood pressure. You should reach your blood pressure below 130, but don't be below 120. And for, of course, diastolic blood pressure, the target is from 70 to 80 millimeter mercury, may be protective and retard the progression of chronic kidney disease. What about anti-hyperglycemic drugs? In type 1 and type 2 diabetes mellitus, proper control of diabetes mellitus have reduced, as we can see, microvascular complications, have reduced, as we can see, macrovascular complications, have reduced the mortality rate. So that's very, very important that proper control of blood glucose level is one of the issues that you can control the complications of diabetes mellitus. But while you are trying to control blood glucose level, don't miss that these patients are fragile and are more susceptible and prone for hypoglycemia. And these anti-diabetic drugs have effects on albuminuria. And again, I will not discuss the anti-diabetic drugs because my dear Professor Dr. Yasser will discuss this later. So that management of diabetic kidney disease is multifactorial. We have control lipids through statins and other newer agents. We have to control blood pressure by ACE and ARBs and mineralocorticoid blockers and renin inhibitors. They have a direct, of course, protective effect of the kidney, while you should, of course, control blood glucose level with the best, of course, protection for SGL2 and glucagon-like peptide 1 agonist. And this, of course, will be another lecture. What about other drugs, not rather than, of course, oral anti-diabetic management? The mineralocorticoid blockers may play a role in protection of diabetic kidney disease. And here, the third generation finerenone is a very, very important drug that may help in retardation of progression. And there was 2 ongoing studies have finished very recently and have found that these drugs are renoprotective drug. What about other trials? We have the imericurine trial. The imericurine trial have used this drug, which is a direct renin inhibitor. When you have used these drugs, when you have used higher dose of this drug, and it was compared with candesartan, it was not less comparable than ARBs, and they have found to be renoprotective. What about inflammation? You should control inflammation in diabetic kidney disease. My dear Professor Dr. Yasser will speak about SGL2 and their recent efficacy on suppression of inflammation. But we have other players. These players, such as pentoxifellin, which suppress inflammatory cytokines. We have the parasitinib, which is JAK1, JAK2 inhibitor. We have other drugs such as the chemokine ligands and the chemokine receptors antagonist, and drugs which act on the phosphodiesterase, of course, and inhibit them, and other drugs that can act on transforming growth factor alpha. What about the SONAR trial? The SONAR trial have used a new drug which is atrasentan. Atrasentan, this is endothelin receptor A antagonist, and they are very promising drugs. As you can see here, they have changed the composite outcome significantly. They have preventing doubling of serum creatinine significantly. They have preventing end-stage kidney disease significantly, and they have reduction 50% in GFR significantly, so that we have a future for other drugs such as this endothelin receptor A antagonist. What about the clemizine AST120? This is a probiotic that can be taken orally, and it's taken orally in this situation. It's a probiotic prevention of generation and absorption of uremic toxin that may deteriorate, of course, chronic kidney disease. What about targeting oxidative stress in diabetic kidney disease? There are new studies now. This study will act as anti-inflammatory to suppress the apoptotic signaling pathways so that it will reduce inflammation. So anti-apoptotic measures may play a role in protection of our kidney. What are about role of epigenetics? This is the future now for epigenetics. As we can see, if you have a patient with environmental factor and epigenetic affection of the molecule through methylation, you will have expression of diabetic gene and diabetic, of course, kidney disease. But if there is a success towards unmethylation of this epigenetic, you will of course have no gene expression in this situation. Several drugs regarding epigenetics are being in the market and are now used in the research work towards retardation of the progress of and the changing the history of diabetic kidney disease. Of course, a lot of drugs are in the research now. What about a promising outlook for diabetic kidney disease? As we know that the RAS system, either ACE inhibitors or ARBs, they have hemodynamic factors on blood pressure, preventing activation of intercellular signaling pathway, reducing inflammation, oxidative stress, and prevent cellular dedifferentiation and have effect on epigenetic pathways. These drugs may help, of course, in retardation of the progression of chronic kidney disease. Other drugs, such as glucagon-like peptide 1 agonist and SGL2, they have also a lot of metabolic and hemodynamic affection, and I will not discuss these drugs now because this is the lecture of my dear colleague Dr. Yasser. And we have other players. We have the apoptotic signal regulating kinases, and we have the inhibitors of demethylation, so that they may help in changing epigenetics and improve, of course, the process of diabetic kidney disease. So that we have multiple players. Some are now in the practice and others are in the research work. What about autophagy? This is very important. Diabetes mellitus may inhibit autophagy, which means that I am declining the several metabolic pathway that can affect the diabetic kidney disease by enhancement of autophagy. In this situation, you may have a novel drugs towards retarding progression of the chronic kidney disease. Others, the future also for insulin-producing cells from adult human bone marrow, mesenchymal stromal cells. These are investigational, of course, researches that may help in cases of this situation. Primary prevention of cardiovascular disease. We have a lot of articles until now that may help in this situation. What about nutrition therapy? We have discussed that previously, but the routine use of chromium or vitamin D supplements or other hair supplements or curcumin or others, it has of no benefit and it is not recommended in the guidelines, and these are outside the guidelines. Also, melatonin and distillation to adipose tissue and metabolic syndrome is a new entity now in retardation of chronic kidney disease. So that the comprehensive multifactorial management, as we have seen, have preserved here my GFR and prevent deterioration of my creatinine deterioration. And the comprehensive multifactorial management, which I have mentioned previously, as we can see here, the intervention have made lesser incidence of end-stage kidney disease or diabetic cardiovascular kidney disease, or of course other, deterioration of kidney functions. So that what is the dream? The dream is implementing personalized medicine, which means that to have different therapy options, as we have mentioned previously, and to know what's going exactly inside my patient through genomics, metabolomics, proteomics, and others regarding several organ affection, and to have the proper diagnostic procedures, and then according to all these scenarios to individualize each patient, whatever his proper way of management, to reach a personalized treatment for each category of patients, not one fits all. So that the effective management of diabetic nephropathy, the holistic approach, intensive control blood glucose, and don't mean that your patients may liable for hypoglycemia, control blood pressure, use of ACE and or ARBs, lipid lowering, aspirin, smoking cessation, exercise programs, dietary interventions. All these may help in effective management of diabetes and control of diabetic nephropathy and delayed progression of diabetic nephropathy. So that a doctor is a student until he dies. Once he considers himself not a student anymore, the doctor inside him dies, and thank you. Thank you.
شكرا لك دكتور حسين.